I think we'll get going. Thanks to everybody for coming to what is undoubtedly the best panel of the day. I'm Tim Size. I'm Executive Director of the Rural Wisconsin Health Co-op and an honor to be the moderator. Also, it's kind of a fun fact. It's the first time I ever moderated a panel that everybody on the panel other than me was born and raised in Wisconsin. And probably all rural Wisconsin? All right. So it's a very qualified group. The topic we're going to discuss today amongst ourselves and with you is strategies for rural communities, collaborations to strengthen health. Rural communities often have distinct healthcare needs compared to urban counterparts, sometimes exasperated by demographic and social trends. This panel will identify key issues in rural healthcare and will discuss the promise of collaborations to improve the health of people in Wisconsin's rural communities. The format will be similar to this morning, 20-minute opening perspectives or 5-minute max each. And if, John, if you don't have any, that's okay. You can just wing.
I prepared something
Okay.
in the last 30 seconds.
Then we'll have 45-minute moderated questions. Unlike this morning, if the spirit moves you that you really want to say something or ask something, I would encourage you to do so. I think it makes it a little more interesting if someone gets totally outraged at something that's set up here. And then we'll have 15 minutes of the official audience Q&A. I would add just one lens that I would hope you would use both on the panel and in the room is to go beyond thinking of health policy as just stuff the public sector does, that just is regulation or just our laws. There's an equally powerful set of policies, both explicit and implicit in the private sector, and insurers and health plan systems or whatever. So I think when we're called to talk about issues and policy, it's helpful to use both of those lenses. Our goals for this session are pretty much, I guess, like the morning sessions. Hopefully we'll hear multiple perspectives, learn from the research, data, evidence, and experience, hear innovative solutions, and show opportunities for collaboration. And I think that's both the conversation amongst panelists as well as with you. I will not going to read the entire bio that are in your agenda book, but I do want to highlight a few for each of our panelists. And I'm going alphabetical, which is actually coming this way. So John Eich leads the Wisconsin Office of Rural Health based at UW-Madison. He's raised in rural Wisconsin. John now works to improve access to and quality of rural health care around the state. His experience and skills focus on program planning, evaluation, systems analysis and design, and community development. He previously directed a county health council in southern New Mexico, recognized by the state at that time for its leadership in developing evaluation and data assessment tools. Jen Kowalkowski is a PhD student at the UW-Madison School of Nursing, also a Wisconsin native who grew up in a small family-owned dairy farm, I think 3 generation, Jen?
Yep.
Yeah. She is an RN who uses socio-ecological framework to investigate health and well-being amongst rural populations, including influential factors like educational preparation for RNs and related workforce issues. Her program of research focuses on reducing rural health disparities through community capacity development and community-based, culturally relevant strategies that reflect local values. Senator Jeff Smith represents the 31st Senate District, which includes 9 counties in rural western Wisconsin. He serves as the ranking member of the Senate Committee on Agricultural Revenue and Financial Institutions. Before serving in the State Assembly, Senator Smith was a small business owner, served on the Brunswick Town Board as chair. He and his wife, Sue, live on their farm in the town of Brunswick, caring for horses, chickens, dogs, cats, a llama. I guess in America you call it llama, but I worked I spent some quality years in Bolivia, and there they make a double L-Y.
Oh, boy.
And on their land. Laura Waldvogel has been president and CEO of Family Health La Clinica since joining the organization in 2015. She has extensive experience in integrating medical, dental, and behavioral health services in primary care settings. At La Clinica, Laura has made it a high priority to strengthen current and create new collaborations with other area community organizations and has dramatically expanded access to essential services as a direct result of these strong community partnerships. We're already ahead of schedule, which is good. So, John, take it away with your 5 minutes.
So this morning, I saw in one of the other panels, people really sort of like read from their treatise, and I realized I was not prepared for that level, but I will say this, I thought we'd kind of get right into the questions, but I will say this, just to start it out with a little controversy, which is always fun. I'd like to push back a little bit on the theme of collaboration. I think that rural already collaborates very well. I think when you have a smaller pool of people to do the work and people that know each other well, they tend to wear many hats. And so I don't think that we can look at a small town or a rural area and say, well, what you folks really need is better collaboration, because then that will help account for the factors, very large societal factors that have put you in a difficult position. If you could just all collaborate better, then this would solve the problem. Also, that frees us from having to bring up any money for your issues, which is really an issue as well. So like I said, I do think that collaboration is important, don't get me wrong. But I do think that rural already is quite good at that, and I hope that we can move quickly past the idea of how can we work better together and get into how can we address some very large issues and how to provide access both physically and financially, as our keynote said this morning. So that's all I got.
I also agree with John on this one. Having lived and worked in rural communities, I don't think that anything but collaboration really occurs there, unless, of course, you're my father, in which case you do everything alone. Thank you for laughing. We need a little levity there. If for those of you who were in the session in this room earlier, you're well aware that aging populations are growing at the fastest rate in rural communities. So in many respects, I don't think we can afford to think about policy, particularly anything remotely related to health, without thinking about rural. We are completely underprepared to deal with rural health needs. Not just here in Wisconsin, this is really across the United States. And I think we can learn from some of our global partners about things that we could potentially do differently to address some of those health needs. And thinking about my perspective, there's a couple things I would really encourage you all to think about today, and what collaboration looks like. Try to leave those things behind, because collaboration can look very different if you allow yourself to be creative in terms of what that looks like. And capacity also can look very different if you allow yourself to see capacity in a different way. So for folks who've worked in rural communities, particularly in rural hospitals, you do a lot with very little. I've had folks tell me we do more with less. And I've talked with some folks from academic communities who have said, well, they don't have very much there. They don't have much to bring. And that's why I've started thinking about capacity very different. Sometimes motivation in and of itself is more capacity than financial dollars. I also really encourage folks to think very differently in terms of kind of bringing a research focus here, to think about doing research in rural communities and around rural health policy in particular differently. I do not believe in working in silos. So I don't think we can look at policy, education, practice, and research in silos. We have to look at how do these things integrate. So how does one influence the other? How can we use one to do another thing better? And I really try to do those things in my own research. I don't believe that we can really be wise about the health policy choices that we're making without thinking about how are we educating our providers? What are the local policies and other policies that are governing how our healthcare providers are being educated? And we can't think about what our practice models look like and where we're putting those people. And so, again, I really hope that we can think about this conversation when we think about collaboration, thinking about it across all levels as well.
So, from my perspective, we're all going to go down this line up at least to this point and say one question is collaboration thing,
Right.
Because I'm in politics. That is a foreign word in the state legislature, and I think in Congress as well. Collaboration, wouldn't that be wonderful? So we have a long ways to go. So I don't want to be the Debbie Downer here all day long, but so I'll try to be a little more positive as I move along. Because I've seen a lot of great things happen. But you know, one thing that was mentioned in the previous, pretty political statement, I think, but it's really true. In the previous session I sat through, was that something got done on opioid crisis only when someone of power was directly affected in their family in this state legislature. It's the only reason we started putting money into something that was killing people. The only reason. And so I want to say, Jen, when you say motivation is sometimes better or greater than money, don't say that out loud. Don't say that out loud. We need to be sure that what we do as state legislatures, we do our job. Our job is to protect people, first and foremost. Not with military power, but protecting all of us all around us for their health and their education, and everything else follows after that. So I've served in this is my first term as a state senator. I'm only halfway through my first term. But I was in the legislature 10 years ago as well. So I have experience, and I have experience in different ways that we operate, and there was more collaboration at one time. So let's move back towards collaboration, and I know we're not here about political collaboration, but that's really what I'm here for. And but where I come from, and I have lived where I live right now, I am not a world traveler. I've lived there all my life in Eau Claire County, and have experienced a lot of opportunity where people come together for the right reasons. If we take the politics out of things, people collaborate. If something is moving into their neighborhood that's going to poison their water, you watch people come together and collaborate and forget about the politics that have pulled them apart in the past. So these are important times in the fact that we have to start setting aside those politics and remember what's really most important and why we're here, and collaborating to be sure that our next generation has clean drinking water, that our next generation has the ability to be cared for in important health situations. We have to pay for it. So that's what I'm here for. I'm here to, and I actually, speaking of collaboration, I hope that we get some really good, powerful input from you during, I think discussion back and forth is the greatest way that we all learn and get something out of these. So thank you for being here today.
So I've been lucky to have worked within the community health center sector since 2009. And federally qualified community health centers, one of the directives is that we collaborate. We collaborate within the communities that we serve, and we collaborate with those who we serve. I also spent most of my life in a rural environment. I grew up on, just like Jen, on a dairy farm. I understand rural, and I feel the most comfortable serving in a rural environment. When it comes to collaboration in a rural environment, the innovation, I've never seen anything like the innovation that occurs in a rural environment. It is something to behold. Some of the things that we've been able to accomplish at Family Health La Clinica, which is a federally qualified health center that serves the migrant and seasonal ag worker population, as well as the traditionally underserved population in a 10-county central Wisconsin region. They're incredible. Some of the things are related to the behavioral health crisis, the opioid crisis. Some of them are just the lack of resources, what we would consider resources available in the region that require us to share and require us to not duplicate efforts. So I love the word collaboration. It is something that it's just inherent when you are in a rural environment. It is something that I think other environments actually should take notice of and learn from. Because we have some models that are very impressive as a result of people being willing to come to the table together. The community health center model does require collaboration, but it also requires a 51% majority board of those who are served by the community health center. So you're getting patient perspective, consumer perspective as well. So there's just so many different ways that that we can talk about this, and I'm looking forward to doing just that. So,
Right, thank you. I'm not supposed to do too much narration as moderator, but
good luck.
yeah. But my questions can be extended. I do believe collaboration is alive and well. Laura and I were in rural Wisconsin. Laura and I were talking earlier that we're both glad that we ended up working in and for rural Wisconsin because it's fertile soil for collaboration more than many other parts of the country. Having said that, I think there's a lot more opportunities for punching holes in silos and building bridges than maybe my colleague John thinks. But the first question, and this is for Jeff, it's a little bit of a zinger on the collaboration issue, is we hear a lot, and it's a phrase I don't particularly like, but we hear a lot about the rural-urban divide in this state and in our country. So how can rural and urban communities better collaborate or collaborate at all with each other to improve the health of all of our communities?
Well, it's real. It's real. You know, but mostly the rural-urban divide occurs because we don't understand each other. I'm not going to say that I should or could understand what happens in Milwaukee and why things happen a certain way in Milwaukee. But certainly someone from Madison or Milwaukee, if they believe they do, they don't understand why things happen the way they do in rural western Wisconsin. But I'm not going to be all negative here. We have a great collaborative effort happening in western Wisconsin at this very moment. So it can happen. And it happens, though, because we happen to have a great UW system. And we have some great medical systems as well. We have Mayo Health System in Eau Claire, and we have the UWEC in Eau Claire, which happens, timing is everything, right? And they happen to be in great need with a 60-year-old science hall that is falling apart and doesn't meet the needs of today's current science. And so the collaboration came when Mayo, realizing that they also needed to grow and they want to make western Wisconsin the center of rural health care at least in the Midwest. And it was the perfect storm. And Eau Claire and UW Eau Claire and Mayo have collaborated to put their forces together so that now we have in this past budget actually passed $125 million initiative for the first half of moving this project forward. And Mayo is contributing every time we pass something. They contribute their millions of dollars as well. They have now made the greatest contribution to any university that anyone has ever made in this collaborative effort. So it's perfect for this conversation to demonstrate that collaboration can happen because of the great need that is seen in rural health. Now, and we all know what most of those needs are. We're going to probably repeat them and talk about them over and over up here. But I am really excited about that particular piece of collaboration that comes from the university system, from a very large world-renowned health system as well, that's going to be planted right in rural Wisconsin, and for the sole purpose of meeting those rural health care needs. So there's hope. So it really happens.
Jen, maybe a follow-up. You just share a little bit of some of your work that you're doing with UW and rural communities, same thing?
Absolutely. Before I forget this, I do really want to dovetail on what the senator had mentioned about rural and urban not understanding each other. I think the greatest opportunity that we have really to collaborate is to listen. I think we spend a little too much time talking about what we want and what life is like for us. And sometimes we need to give our partner space so that we can understand what their lives are like, and then we can then have that same opportunity, so more listening. And then I'm known as the intern that never goes away. I've been working on a project with Tim and the rural Wisconsin Health Cooperative now for over a year and a half, I believe it is. But I've been trying to work with essentially bridging academics and our community hospitals and trying to find ways that we can really showcase the best of both places. And really what I've come to discover is that there are ways that places like UW-Madison and other schools in the UW system, we have a lot of assets that we could probably use differently. And one of those things is we could use our faculty differently. So we don't have a lot of rural people on our nursing faculty. That's a little bit different in medicine, but also in pharmacy and physical therapy. And you look across the health disciplines, and rural is not represented as well as other places are. So we could structure our faculty differently. We should integrate rural into how we educate. It shouldn't be the other. I actually worked with some senior nursing students. It's their last year in nursing school, and I did some projects in their classroom, and they had shared with me that until I came into the classroom, they never knew about rural health disparities. And to me, that's shocking, that anyone could get through a health programs course or through a health professions program without understanding there are serious health disparities, or even understanding that how healthcare is reimbursed in rural communities and community access hospitals and all these things are different. And there is a huge opportunity for schools of nursing, schools of medicine. So I'm a nurse, so I can't help but talk about school of nursing, but just insert health professions. But really to collaborate in terms of how are we partnering to expose our students to rural. So the way that we typically do it in nursing is someone from a school of nursing calls up and says to a hospital or a clinic and says, hey, we'd love to bring students to your facility on Tuesdays and Thursdays. Can you take us? And people want to, so they say yes. But that yes doesn't mean that the students are there on days that anything of any interest is happening. So maybe everything happens on Mondays and Wednesdays. So the students have what they consider is a horrendous experience because nothing happens in these rural facilities, when in fact that's not the case. There's also a lot of myths and misperceptions that need to be eliminated. There are still students in every health profession on this UW-Madison campus that think that only the washouts go to rural facilities. You can't get a job at Mayo, you can't get a job at UW, and so you have to end up going to rural. Think that quality of care is lower when in fact many communities it's actually higher in rural facilities. And so, I mean, I could go on because I've been doing this for quite some time, but those are just a few examples of how can we do better. So how do we engage in conversation between academics and our rural facilities to showcase what's really happening in these communities, provide a high quality clinical experience that the students engage in and enjoy what they're doing and actually get to know the community. That's an incredibly important piece of high quality experiences in rural settings is it's not just the facility and the job, it's the community and understanding what's happening in that community.
All right, John, last word on this first question?
Sure, just a quick point. I think we've learned in things like international development that Americans can't go to sub-Saharan Africa and tell them how they need to solve their problems. We've learned this racially, where we say people that are white cannot necessarily go to a primarily African-American community and tell them how to solve their problems, and I think we have to do the same with urban and rural. I think we have to say that sitting here in Madison with our urban perspectives, there are things that we don't know, and in order to come up with policy or to make some decisions, we need to spend some time there first. We need to learn how those dynamics feel in person and kind of in your skin before you can really tell some folks, well, here's how you ought to solve that problem.
You're good. Okay. Next question for Laura. How can collaboration amongst rural providers best enhance service delivery and improve care coordination?
Well, when you collaborate in a rural environment, it's typically out of not only necessity, it's also out of desire, but you create economies of scale when you're collaborating with one another that you don't have as an individual provider. We have a number of circumstances that happen. They're both fortunate and unfortunate experiences. So in central Wisconsin, there's a collaborative called the Central Wisconsin Health Partnership. It's a 6-county group. They collaborate to do their community health needs assessments. They have a community health improvement plan that they work on together. They have their CCS is a regional CCS group, which is that Comprehensive Community Services Program under Chapter 36. And so it's the 6-county initiative that works together to kind of combine resources so that they can, because they have shared experiences. The other thing that we see, though, is a lot of movement between staff amongst these providers. Most recently, for example, we just hired a provider who was working with one of our partners in a rural health clinic, which is now probably going to jeopardize the ability of that health clinic to stay open. So it's critical that we're kind of working together to come up with ways to sustain both, because it does nobody any good to just continue to rotate staff amongst one another. But we see that over and over again. So coming to the table time and time again, even when things get tough, because they do, we do take things personally when things like that happen. But coming to the table time and time again to strategize around how can we address that. We have an initiative, again, coming out of that Central Wisconsin Health Partnership, where we are sharing providers to extend the reach of the primary care providers in the region. So this came directly as a result of the opioid crisis. There are several of the counties that are in that Central Wisconsin Health Partnership that were identified as very high need due to ambulance runs and overdose and deaths. And there were some of the newer partners that really had not been part of the partnership before, but out of just sheer desperation and necessity, you come to the table together to come up with a way to address this. So what the result has been is a model of care around extending the reach of primary care providers by sharing specialists. So we have a psychiatrist who's an addictionologist who provides collaboration and support to primary care providers in other health systems who are want to prescribe or are prescribing medication-assisted treatment options for people with opioid use disorder. And we also provide care coordination and case management. So it's a multi-system approach. So again, it's all of these systems coming together, being willing to put some skin in the game and work together to address a health issue that none of us could have done on our own. It also required some grant funding, and we had to stick with it because when we first wrote for it, we were not successful. But luckily, we joined 2 other health centers in the state that were already funded for this type of funding, and we developed this program. So that's one way, the economies of scale, leveraging the strengths of one another, making sure that those that are at the table we live and work in those rural environments. So we have a vested interest in seeing these initiatives succeed. I think those are the big things that I wanted to say about that.
Very awesome. And John?
Wow, all right, yeah, actually. Oddly, I do have a thought about that. No, that's great. But the thing I was thinking about with this, I think where this can break down when folks are trying to do the right thing and collaborate is when we have forces outside that pressure us against collaboration, and I'm talking about health system networks,
Yes.
referral networks.
Yes.
So you've got a community where the natural fit or the closest provider or the closest inpatient access is close to you, but you're not allowed to go there because either it's a different
Right.
system or an insurance company says that's not in our network. So I think, again, those are urban forces, those are large forces, and they are working directly against, I mean, in their own best interests, so good for them, but they're working against our natural ability to collaborate.
That is such a great point, John, and it is something that we butt up against all the time. Where we are serving, we have to contract with, I want to say there's at least 12 MCOs that we have to contract with. We often are delivering services without getting paid, and it is life or death. It absolutely is life or death for the people, so we have this great program, and the people need to get seen, but we're not going to get reimbursed for it because for those reasons. I mean, it's just how it rolls. So those are policy things that do need to change. I told Tim earlier, I do not see myself as a policy expert, but I am an expert at getting things done. I just know how to dig in and do it, and then maybe it was wrong, but we tweak it as we go and we figure it out together. That is what I know how to do.
Yeah. And what did I say? I said you are a policy expert because you do all sorts of really mission-driven work that are policies for your organization.
Absolutely, so I concur with him
right.
on that. However, in a rural environment, that is how things are done. I mean, you really don't think too much about it, you just get to work and you address the need. And all of my colleagues in the community health centers in the state operate the same way. But that particular issue and others, like getting people privileged and credentialed and impaneled and all of those things are real barriers. But it doesn't, at least not in our environment and with our partners, it doesn't stop us from continuing to serve the people that are coming before us because we have to.
Laura, you have inspired an audience member. The spirit is moving it.
I agree, that's a great point, and I have a follow-up question on it. My background is that one day a week for 35 years, I held arthritis clinics in rural Wisconsin while being based in Madison, and so became an honest broker for my rural colleagues, and then served as regional medical director for Physicians Plus for a decade. And the question I have is that we were whipsawed by the competitive forces of the unique Wisconsin penetration of the large systems and their affiliated insurance companies. And Tim, the stuff you and Tim Bartholow and others did to sort of buffer the rural health systems from that marketing stuff. And I fought the battle, caught in the middle between what was best for rural and what I was being told to do by my big system bosses. And the question, I think this is important even from a legislative perspective, because unless we create safe zones for rural health care, my sense is that this is, what I'm hearing from my physician colleagues is that this is getting worse rather than getting better. And I don't know how other people in the room feel. But I'm wondering what your sense of the trajectory of this is, and whether really some legislative relief for the rural health systems to create a level playing field for the interests of rural health care as opposed to the marketing interests of the big systems might be.
Jeff, do you want to?
You know, I'm so glad you brought up network, for instance, and competitive. And we live in a culture in this country of everything's competitive, not collaborative. It's competitive. And so you're exactly right. This is unbelievable. Since HMOs came into being in the 70s, that it just exploded. Then they took over the health system. Thought it was a good thing. Oh, this is going to be a collaborative. It seemed like a collaborative thing, you know, a co-op type of thing. And it's actually gone the opposite direction. And in fact, Representative Kolsky and I have legislation that we just recently finally introduced. I say finally because we've worked a long time on getting it right, working with the stakeholders, but that's related to the issue with out of network and surprise billing, right? So people just honestly go because they're sick. They have an issue and they trust their clinic, their doctor, whatever you got to do. Okay, I show up and I see my doctor that I know is in my network, and I'm in my clinic that's in my network, but then somebody else ends up showing up as an anesthesiologist, this is always my example, who is not in your network, but you don't know that. And then months later, you're stuck with a $10,000 bill that your insurance company says, sorry, you didn't check with us first when you were laying on that table. So this is a serious problem, and this is just one piece of legislation, but we do need to do much more to protect patients, and let's face it, we need a single-payer system in this.
Well, and I will say that the trends too, so we're the Wisconsin Office of Rural Health, there's one in every state. So when I talk to my colleagues, a lot of them are still operating in states where there are more independent, small rural hospitals, et cetera. And so we've always been the ones to say, well, actually, I think we're on the leading edge of this, at least for outside of California and New York. We are seeing more systems. I remember when Aurora was the huge system, and then Aurora merged, and it's going to go, that's going to get worse or better, however you look at that. And especially if you look at how they're focusing on costs, they're going to want to squeeze costs, and it doesn't matter what party you're from, they're going to want to squeeze costs. And when they do that, the only, since they're not going to release regulationary burden in the same way, the way they're going to do that is by getting bigger for scaling. And so this is the future, is very, very large systems where they're going to be making decisions very remotely with accountants versus in a community where we know each other, and we really do need to keep doing that nursing home in the community even though we're not making money on it.
Yeah, let me just add a couple comments and then.
I got something to say.
Oh, okay. Let me add my 2 comments and then Jen, and then we'll go on to the next question. First thing is, there is diversity of behaviors among systems in my experience, and I would not disagree with some of the worst case scenarios I just heard. I have seen other behaviors that are more cooperative. The second thing I would really push, over the years when we've had network adequacy issues, we have found the insurance commissioner's office often quite helpful, but it depends on people being willing to actually file a complaint, either on behalf of someone or themselves or patients or whatever. I think the professionalism in that office I've long been impressed with. But if people don't bother, and I go and I say, wow, network adequacy is a real issue, because I think it is. If the data doesn't support me because people haven't shared their experiences, that makes it harder to get work done. So, Jen?
And kind of to dovetail along that, one of the things that really does move the needle is our stories, personal stories. When healthcare systems really started centralizing, nobody really thought too much of it. It kind of got worse and worse and worse, so to speak, with rural hospitals closing and services centralizing even more. We now know that with the number of hospitals that have closed in rural communities, the number of OB services that are no longer available in rural communities, that mortality rates have gone up. And unfortunately, and I'm somebody who comes from a rural community, and I'm still really bad at this, folks in rural communities tend not to speak up when things go bad. You tend to put your head down and you tend to work harder. And, and you're also talking to somebody who grew up on a farm. So you talk about putting your head down and working harder. And really what folks in rural communities really do need to do is really start telling those stories. Those stories are going to move the meter when it comes to legislation, when it comes to policy, when it comes to really getting your senators to hear. I mean, again, kind of going back to that opioid crisis in Wisconsin, it wasn't until it hit home for someone in a very powerful position to make that story heard, despite the fact that many people were dying every day. It just wasn't the right person yet, because that story hadn't been told. So I think we have a lot of stories we can tell, and I think it's really important that we do tell those stories. There's another piece to that I think is really important, that is coming from the provider end of things. I know from working in rural facilities, you spend a lot of time with coordination of care. There's nobody else to do it, so you're going to do it. And you bend over backwards to make sure that these folks don't get lost in the system. And if you think about, and you think about it strictly from an economic perspective, think about all the waste. Think about all the care you're not giving to other people because services are not available necessarily where you are, or you're chasing down other things. And so again, I think we have a lot of stories, but we just need to tell those stories.
Our next question, actually for John, plays off of that. There are numerous efforts underway to improve access to healthcare services in rural communities. What strategies do you believe the research and your experience suggest are most effective?
So I think most of the times when people first start talking about access, they're thinking about hospitals and clinics. Our office did, and I'm not saying that's the only thing we should pay attention to, but to address that, our office did a drive time analysis to emergency rooms. 92% of Wisconsin residents are within 20 minutes of an ER. 99% are within 30 minutes of an ER. And so that's just to say that while there certainly are gaps in the state, I think that for the most part, we're doing pretty well as far as providing physical access to a clinic or hospital. Now, whether or not a certain person will go to get care because either the distance that they drive to it or their insurance is an entirely different matter. But I would say that honestly, I think we're doing quite well. Primary care is what you find in rural. So if you need specialty care, you're going to need to go to an urban area for that. Well, not always, but often that is what's going to happen. There are specialty providers that will travel, but it's not the same. OB is definitely something that we're seeing. Again, another analysis that we did shows a decline in Wisconsin for OB services. It's not as stark as it is in other states, some other states, but it is nonetheless a trend that is going in a clear direction. And when that happens, that means that births are more likely to to not go as well, or if something doesn't go well, to go very poorly. And then I do think that there are ways that we can look at that, and so this gets back to the spirit of collaboration. I think we have a system, if you look at OB specifically, we think, or obstetrics, we think about an OB. I think we're not utilizing other provider types like nurse midwives and other midwives. Sometimes a professional territory can get in the way of the sense of what could be innovated, what could be utilized. And as far as telehealth for specialists, it certainly can be used. Again, it's often an urban solution, like, well, why don't they just all have doc and a TV? Clearly that does not work for everything. And when it does work, and sometimes it works very well, again, we get back to this referral network issue. So there was a question back there.
Is there a question?
Yeah, I don't need a microphone, but I can talk loud. My name is Tricia Sieg. I'm from the Employee Trust Funds. I was born and raised in Granite, Wisconsin, which we didn't get a stoplight until 20 years ago when we got a prison. So that's how we're doing. My question is, what we're seeing from our members, we Employee Trust Funds, we do the health insurance for all the state employees all over the state. We're seeing a lot of our rural members that are using emergency rooms for things that don't really call for an emergency room because there isn't any other option. Emergency room might be 20 or 30 minutes away, but if they have something that's not an emergency and it's a Saturday, they don't have anywhere to go. Whereas here in Dane County, there's all sorts of clinics that are open on weekends and stuff. Are you finding the same thing in yours, that rural members are going to emergency rooms when maybe emergency room isn't the best thing to go to?
So our data doesn't address that. It sounds like you've got some data right there in your experience, but I'd kick this to Tim.
Thanks, John.
You're welcome.
Yeah, and I would address it almost a different way than your intent, because I think it's not an unusual observation that you made. I would add to it another observation, though, and maybe I'm wrong in what I understand about employee trust funds, but for some state employees, they may find it less expensive to sign on with a plan that's only offered several counties away, particularly if they're young and healthy, knowing then that if they need emergency care, they're able to get it locally. And I think that phenomenon, to a degree, it's true, and I have more anecdotal evidence than data, that tends to undermine the rural network. So, I give you the opportunity to respond if you want to.
There's clinics open in Dane County on a Saturday? Yamas and
But
clinics open on Saturday.
It's a good example. The Employee Trust Fund, who I have the highest, Eric Stansfield and I are still close friends, and he ran it for years, and they do great, awesome work. It's one of the best models in the country. But I sometimes wonder about policy decisions made that are best for the employee and the employee's insurance, what impact they have that is helpful or not helpful to maintaining rural infrastructure. But,
We've got a clinic expert in the audience.
oh, Greg Nitsch.
Just to elaborate on this last point and the idea, it's good that we have that kind of availability for emergency rooms. But throughout rural areas, if you go to the emergency room, like 37,000 people do every year for an oral health problem, and you get opioids prescribed or antibiotics, that's not the right place to go. And we see people who've been to ERs 2, 3, even 4 times before they find out about us and get to us. If you go to an ER and it's close, that's great too if you overdose. But then coming out of that, try to find services to help you with leaving your substance use disorder behind.
Yeah.
So we got part of the infrastructure in place, but there's still big gaping holes as it relates to dental care and as it relates to substance use disorder services, particularly for adolescents.
Yeah, excellent point, and short-sighted on my point. I was focusing on medical, but you're right, dental. If you look, we map the health profession shortage areas. When you look at primary care, it looks a certain way, a sort of a quilt, so to speak, of shortage areas and non-shortage areas. When you look at oral health, the shortage areas are much more plentiful, and when you look at behavioral health, it's practically the entire state. So you're right; those are entirely different issues, and there are definitely gaps in services.
Maybe La Follette could bring us back next month, and we could have a whole day just on emergency and EMS, because it's the Achilles heel, I think, of much of what we're doing in rural, particularly the EMS. I mean, that's a whole other conversation. Any other responses from the panel on
Yes.
the question I just asked John?
Yeah. Something that I think about all the time in these types of discussions is I feel like we are using cognitive frameworks about what we think healthcare is and how we currently deliver healthcare in an era where none of those things hold anymore. And it's hard to change, and I know that. I mean, change. I mean, let's be honest. Change is not always pleasant. You know, even great change. I mean, having a kid is exciting, but it's exhausting, right? But you know, if we continue down the same road of saying we've always done it this way, this is the way we do it. It's going to be just like, you know, every time that you update a computer program, it's got the same garbage in it, and it just gets more complicated. It's the way I think about things. So that's always a big frustration of mine. And I also just want to point out, I'm gonna throw my dentist under the bus on this one. So David Gunderson, for those of you who know who he is, he's an awesome guy here in Madison. He's been doing wonderful dentistry, public health type things for many years. And for anyone who has an emergency department and you want to really look at reducing opioid usage in your emergency departments around dental care, give him a call. He'll come out and he'll do some work with you.
I got to add something here to it on these strategies. Broadband expansion. We've talked about all of these numbers, and sure, you might be 30 minutes away or 20 minutes away, but and we continue here all about the telehealth is coming, e-visits are coming, and are already here for many. But one of the things when we talk about the disconnect between urban and rural is when I talk to any of my colleagues here in Madison, and oftentimes say, well, I live 5 minutes from the city of Eau Claire. I cannot stream anything. When they talk about this great new Netflix show, or they talk about this other thing going on, or why didn't you join in on this teleconference? It's because I can't do that. I can't do that. I have to go somewhere and to a restaurant or someplace. So if we are going to advance with all the things that's being talked about, we have to also take care of these other
Yes.
issues, which means being serious about connecting everyone in their home, in their business, and you want to talk about making the investment up front to make it cheaper down the road. This is one of those things, and we have to make that investment in fiber to every home.
I would agree with that. I have the same experience in Neshkoro, where I live. When working down in Watoma, I have satellite. It's very expensive, and it's crap. Sorry, it's no good. I can't work, and certainly can't stream anything like I want to watch. There are a couple of other things, you know, and I'm sure we'll talk about them as we're going on, but integrated behavioral health within the primary care setting, where you're doing an intervention right within the primary care visit, school-based services, school-based dental, school-based medical, school-based behavioral health. Those are great strategies. Hub and spoke kinds of things like we talked about earlier, ECHO programs, where you are capitalizing on the expertise of an expert. Again, using tele, you have to have access to the broadband. You have to have access to that which will connect you to those types of programs. Mobile programming, one of the things that we've had forever to reach the migrant and seasonal ag workers in the state, because we are the one migrant health center, is a mobile unit that literally travels the state delivering primary care to the migrant and seasonal ag workers. We recently updated our unit. It now is able to do dental as well. So we can expand that way. But again, these things they're small programs, but again, that's the point to me. In a rural environment, with local control, some of these things do have to be small. The large approach is not going to work in the regions, at least that my health center is serving.
Why hasn't the legislature in Wisconsin taken a more active role in providing the infrastructure in the rural community? You have a lot of rural representatives. Where are they?
I heard that question earlier from you, right? So I'm here. I'm right here. So it seems that way sometimes. So, and I got to give you a quick anecdotal story on that too, is that not just broadband, cell phone access. I have had to sit through a hearing recently with a room full of people in rural Wisconsin complaining about the service that they have, that the 911 service went down several times. A person died because it couldn't get through. Their house, house burned down, they couldn't get through. In other cases I've heard of, we have volunteer EMS. They can't find somebody within an hour. It takes them an hour to get to their 911 call. So, I mean, we can go on, and so it's that disconnect again, that the misunderstanding from urban legislators, which dominate the legislature, and just can't quite get across to them how important it is, because it's a numbers game. Passing legislation is a numbers game. You got to have that majority who are willing to vote for it with you on this subject and take it seriously. Mm-hmm. Their issues are more serious than my issues in their mind, right? So I think that's the honest answer.
All right, I'm going to go on the hold. We'll come back. Oh, no, I like you. That's right. Go ahead. She was on a morning panel. All right, make it brief.
So this is probably for John and Jennifer. So Jennifer, you talked about health care disparities in rural, and then you talked about access to emergency room. You also talked about telling the stories of lack of access. So in the budget, we know the morbidity and mortality rates of certain populations in Milwaukee, and it gets great attention. It got great attention in the budget. So I'm just asking for my own edification. Are there numbers that say there's great disparity in morbidity and mortality rates in rural areas versus more urban areas, or is that never do we have any data? Because sometimes you just need data to go along with your stories.
So there's data. It's not the best. So with any, I mean, with any data that you have, it comes down to priorities. So, and I'm not trying to make it sound as if I am not understanding to urban-centric needs. It's just that when that is the majority, when you're talking about focusing resources on collecting data from rural communities, that's not the priority. So the kind of data, the amount of data, the quality of those data are really going to depend on the funding that you have for it. And unfortunately, the majority of the sources that we get, the population-based data, don't have enough information that you can actually extract much useful things out of it other than very kind of broad-based things. And another piece of that that's really important, particularly in rural communities, is when you look at occupations. So I also am very involved in agricultural health, and there are a lot of things happening in agriculture, and the very, very little data that we actually have available is striking. But again, it's the amount that we have isn't the greatest, but there are data to support that, yes, there are rural health disparities. There's no doubt about that.
The problem with rural is you have low numbers, and so a lot of times when you want to look at data from a rural area, the data is, the numbers are low enough that they won't want to release that data because you could identify who that is. When we look across the board at different, the incidence of different diseases, you'll see what pops up in rural will be accidental death, both agricultural, motor vehicle, sort of drinking related, deer, weirdly, Lyme's disease, heart attack and stroke, et cetera, are similar to, you get this sort of U-shaped thing where you've got the most urban and the most rural have, in a sense, the poorest outcomes, and then as you dip down towards suburban, you get some of the best. But I would say that the starkest data you're going to see actually does come from Milwaukee and the infant mortality. That's a striking difference. For the rest of it, it's because people in rural tend to be, they're older, they're sicker, and they're poorer, less likely to be insured because they are either working as a single proprietor or stitching together several jobs, so they don't have the insurance access. But that would be as
I
expected.
need to move on a little bit.
Sorry.
No, it's good. Jen, workforce training, recruitment, and retention is a major concern across the healthcare continuum. What models do you believe have been successful in addressing this challenge?
And I will try really hard not to go on for an eternity because
You
I
won't.
think I could. Just
We'll
cut me
sit
off,
back.
Tim. Just sit back. Honestly, I really think it has to start long before people ever get into school. We need to recruit people from rural communities. There is some evidence to show, and believe it or not, it's not as strong as we think it is. There is evidence to show that people from rural communities, if they get into a health profession program, that they will go back to rural. But we're doing a really poor job of actually attracting those folks. So I grew up outside of a town of 1,000 people that still doesn't even have a stoplight. We have a blinky light at the four-way stop. I'm first-generation college student. I was hopelessly lost when I went off to college. I'm really surprised I actually made it as far as I have. But I was completely intimidated by the application process, and there are a lot of kids who live in rural communities that are just frightened by the process of going through applications, and they don't want to go to a larger school that offers a 4-year bachelor's degree. So they go to community colleges. There's nothing wrong with community colleges. But when we start looking at workforce issues, particularly around nursing, you need to get that 4-year degree, and you really need to go on and get a master's degree and a PhD. Don't let me forget about that.
No,
I'm going to hold you to it.
I'm here waiting.
All righty. So we often try to recruit people in high school. It's too late. You really have to start talking to people actually in grade school and middle school. If you're waiting to talk to people till high school about what they want to do, you've already missed the boat. And you have to connect with those kids. You have to go to their communities, and you have to give them support through the application process and getting them onto the college campus and into their first year of college at a minimum. You're going to see tons and tons of dropout of those kids. It's just the way it goes. So that's just the first piece. Once you've got folks in, we have to make sure they have quality educational experiences. Again, I had mentioned earlier high-quality clinical experiences. So make sure you showcase what these communities do, partner well with your communities to make sure that those experiences highlight those things. Show students that continuity of care, get them engaged with the workplace. Make sure they're mentors within their programs that have rural expertise and can actually speak to all of the great things that happen in rural communities. We have to integrate rural into our curricula, and we have to dispel all of the myths and misperceptions because they truly are rampant and really, I think, incredibly hurtful. Things that have worked well from that perspective as far as training goes, immersion experiences. We do have some immersion experiences in nursing, and there are other programs that do that. It gets kids out into the communities and gets them to know the community. They have wonderful experiences. Specialty tracks, we have that in medicine, pharmacy. I'm working really hard to get one in nursing. PA, we've got that for PA. Actually, PT, they don't have a specialty track, but all PT, physical therapy students, all go out to rural communities for training. So making that a part of training and recognizing that is a part of the continuum of care, because it doesn't matter where you live. Rural people come to the big city for healthcare, and we need to know where they're going back to provide good care. And we also really need to engage our rural providers in shaping our education. So engaging those folks, coming in and sharing what their expertise is in the classroom. Students actually want to see people from rural communities coming into the classroom and telling their stories. Just like our legislators want to hear stories, so do our students. They don't always want to listen to us. There are some programs, too, that are actually rural-based programs. Those have been very successful, particularly for nursing and medicine. So the entire program is delivered in a rural community. Those actually have been the most successful programs. So when you look at, I call it conversion rates, so people who, once they finish, actually go into rural practice, those are the only ones that have actually been successful in raising the number of people who go into rural practice. So for any of you out there who think that having a rural clinical experience in your programs actually moves that dial, it's not actually true. So I did a literature review last year and I was shocked. It's all perception. As far as recruitment goes, the best recruitment tool you can have is positive clinical experiences in a rural setting. So again, it all goes back to what are we doing to get people in? How are we supporting them through the program? And that exposure has to be meaningful. We also need to engage the community while the students are there. So again, the students have that exposure to people while they're there. And onboarding and incentives are really, really important. Rural residency programs for nursing have been wonderful. We've got a great model here that was established in Wisconsin for rural nursing, and it's still going. And
where is it?
It's based out of the rural Wisconsin Health
Okay.
Cooperative.
And now we have two.
Coincidentally. It's been fantastic. We've got the warm residency program here, essentially through Madison. It's been very successful. The one thing I can tell you that most programs don't have, unfortunately, that providers have, and when I say providers, I mean people who can bill, physicians, nurse practitioners, PAs, loan forgiveness when you go to a rural community. Nurses don't get that, typically. Some nurses do, we don't always. But most of those HRSA funds are going to people who can actually write prescriptions and orders. So there's no incentive for anybody else to go there. Wages matter. A lot of people say, oh, the wages are a lot lower in rural communities. I actually see one of our co-op members here. Actually, you know what? Rural hospitals pay a premium to keep nurses. They're not necessarily paying a whole lot less than their urban counterparts because otherwise they can't get them in the door. So wages is not necessarily something you can say, well, the wages are a little bit lower because people really need them. So when we're looking at getting people in those communities, you've got to have some sort of an incentive. So look at some sort of a loan forgiveness program for people. Make sure that they have really high quality onboarding and training because at least from a nursing perspective, you are trained to be a generalist in theory, but that's not exactly how your training goes. You learn on a specialty unit, and then you learn in a very narrow program for the few years you're in, And then you go out and you become an expert generalist in a rural setting and you freak out. And I do mean freak out. I asked nursing students, what would you do if you had to care for a 4-year-old, a 40-year-old, an 87-year-old, and a woman delivering a baby? And you know what they told me? Oh, you can't do that, it's not possible. So if anyone has ever done nursing in a rural community, you know that's very possible, and it's happening right now across the United States. But they don't know how to do it, so we really have to help support them. I know that entering rural practice is challenging for other providers as well, because it is generalist practice typically, and so making sure those supports are there. And then as far as retention, we have to look beyond the walls of the healthcare facility and into the community, because people aren't going to come to a community and stay in a community if there's nothing there, which I know Tim gets very excited about. So if we don't have schools for families, for their kids, if there's, believe it or not healthcare services that are going to stay in your community, nobody's going to want to stay there. If there's not things for people to do, they're not going to stay there. And the other thing that's going to help providers stay is preventing burnout. So how do we get providers and keep them? I don't know. And in order to prevent burnout, but we've got to start really clicking away at that, or we're not really going to make any headway. And we're going to be in this continuous cycle of especially physicians and providers leaving. We're really fortunate in Wisconsin as far as nurses go in rural communities. We've been doing great. Most of our hospitals are doing well, but there are a lot of places where they're looking at significant shortages of the workforce. And to just put perspective on this, I always like to do this.
This is your last perspective.
This is my last perspective, I swear. He's got to cut me off. So if you have 3 vacancies in a nursing, let's say you've got 3 open spots for your nurses. If you have a rural facility, a small rural facility, and your nursing FTE of 24 FTD, and that's pretty realistic, that's 12%, 12.5% of your workforce, nursing workforce. UW hospital type place, that's 0.25 of your nursing workforce. You could absorb a lot in a large community, but you can't absorb a lot in a small community. And so a lot of this stuff, when we think about it, it's a lot more urgent in these smaller communities than they are in the urban settings.
I'm going to hold on questions now. Nothing personal, Lisa, but until 1:15. So we have some really important questions. The next one is to Laura. Access to adequate mental health care is a struggle throughout healthcare, and particularly rural models you've seen be successful.
Yes. So again, talking about community health centers, at least in the state of Wisconsin, and I would say throughout the nation, we have been tasked with increasing the access to behavioral health within our systems. And I know at least within our system, we have done that in a couple of different ways. One is by simply adding behavioral health to our scope of service. So we have psychiatry and mental health, and we also have integrated behavioral health, so right within the primary care setting, because again, in everywhere, but in particular in rural environments, the stigma associated with behavioral health is great. So if you are coming to see your primary care provider and you can see a behavioral health specialist right at the same time for a quick, focused intervention, and then you can get hooked up with ongoing care if that's what's needed, that's a really great approach. And I know that our health center, as well as many health centers in the state, are engaged in both integrated and specialty behavioral health. In rural environments, again, going back to the credentialing, I'm an LPC by training, a licensed professional counselor. I was in private practice for a number of years, and before that I worked with the severe and persistently mentally ill. But when I went into private practice, I was one of 2 entities that delivered mental health in my county, in my environment. And I was excluded from some of the health plans because there were enough clinicians. Or that was the rationale. There's enough of your kind in the region, even though there was really no one else. There was the county and me, and that was it. So it's really important that we address that issue, so that when somebody does want to practice in a rural environment, that we're allowing that. We're experiencing that now within our health system as well. School-based behavioral health is another important program to look at and expand upon. Again, going back to delivering substance abuse services, in particular for opioid use disorder or methamphetamine or any substance use disorder. Partnering with other clinicians in your area so that you're expanding the reach both within your system but between systems is really important. No one system in a rural environment can do all of this, but we can expand through collaboration and consultation. So if I have a psychiatrist who can consult with a primary care provider in another health system, which we can do, let's do that. So then that primary care provider can see the patients in their primary care setting instead of having to wait for months to see a psychiatrist or a psychiatric nurse practitioner. We have to be willing to do that, and we do meet with some resistance with some of the health systems where they tend to want to do it all, and that's great, but it doesn't tend to work when we're all recruiting for the same people, and it's really tough to recruit. And we're all kind of one clinician away from collapse. We've seen this in our rural environment where they have one psychiatrist, that psychiatrist leaves. Guess what? There's no more psychiatry. So figuring out how to work together so that we can recreate that system of care so that every county isn't doing the same thing and replicating the same broken system is really important. And again, the consultation and collaboration model, an ECHO model, those are approaches that can work. School-based, the telepsych, but you have to be able to be reimbursed for telehealth and telepsych services. Those are the things that I can think of now.
I would just add, this is a good example of something that we are only going to be able to solve collaboratively across the whole state. I guess I'm not sure I know of any other discipline that has the shortages statewide as mental health, and I suspect that has something to do with the payment structures, particularly through Medicaid for behavioral health. I mean, I have a family member in Madison who was offered an appointment 3 months from now.
Right.
And so if Madison has troubles, you just know what's going on in the rest of the
The
state.
prior authorization requirements, so if somebody is finally ready to obtain care and is told that they have to jump through all of these hoops in order to get the authorization, these are things that it's not sustainable. So perhaps we'll get some grant funding and we'll develop this program. It's required to be sustainable. It can only be sustainable if you get reimbursed for the services that you're delivering. Right. And so that's critical. And it's not asking too much if you're, following the rules.
Jeff, Jen, or John, the 3 Js? Any comments?
You finally figured that out.
Yeah.
Well, I would say absolutely reimbursement. I mean, that first and foremost, we have to get reimbursement. And not only that, but as you point out, again, the referral networks. I mean, telehealth, this is one of the areas where telehealth really does work with mental health care, but not if you can't get paid for it, and not if the receiving site, the rural site, can't get paid for it.
But it doesn't create more practitioners.
But I was going to say, and as far as that goes, some innovative things, the ways, we have to address, I think, stigma about mental health, and so one of the ways that I think actually community health centers have done really well is they put mental health right next to physical health. So someone goes into the clinic, they're going to the clinic, who knows why they're there, so they're not going to recognize your pickup truck in front of the therapist's office and wonder what's going on there. And then I think it also addressing it from a peer-to-peer level, just to normalize the idea of it's okay to have a family member or yourself with an issue. So out of Milwaukee, a veterans group, Dry Hooch, they have this coffee with a fellow veteran idea where they're just having coffee. That's all they're talking about. And occasionally things might come up, and if things come up, they have people that are trained who know how to refer. So there's like a women's health initiative. Wisconsin Rural Women's Initiative has a similar sort of coffee program. And again, this idea is maybe after church, you get together and you have coffee and people talk about things. Again, normalizing this idea that we all have issues that it's okay to talk about and refer into peer networks. What if we trained every priest and minister in any faith to be a therapist? I mean, that's often a role that we look to them for, so why not start to do it as part of the training? And then finally, some innovative things. If you look at something called Better Health, and Talkspace. These are therapists on your phone. The technology is trying to disrupt this. Now we have to deal with broadband and things like that. But again, if you're going to a clinic where there is internet, we need to get providers to rural areas. We can't just hope for the best because our trends are clear. It's going in a bad direction.
Jeff or Jen?
Well, I'm sorry. I was just going to add one quick thing, and that is because as we are talking rural, and as we all have heard and read so many times over the past several months about the agricultural crisis that we're in, and related to that is, unfortunately, the rise in the need for these services for our farmers who are unfortunately using the route of suicide to get themselves out of the terrible position that they're in. So this has really been I suppose the silver lining is it's shined a light on the great need in rural areas and to break that stigma of mental health and and suicide. So it's been helpful in the legislature for many of my colleagues to actually have their eyes open to this great need, because agriculture has clashed with the needs for mental health in rural Wisconsin.
So to dovetail on that, that's my dissertation, folks. So one of the things I'm actually looking at is essentially what John is talking about, specifically for agricultural populations, and that's social networks. So what is really interesting about social networks is they've actually been shown to improve physical health and mental health. Some in rural populations, in some other populations, more so than other psychological and physical interventions from clinicians. So I'm not saying it's a panacea. There's nothing out there that is a panacea. But the one thing I can tell you about rural communities and agricultural communities in particular is they tend to be very tight and they know each other very, very well. And if we can tap into those resources that they have locally, I think there's an opportunity to really make some headway there. From talking with some folks that I've been working with, my work is primarily in Adams County for this, is everybody said, we were talking about 3 individuals in particular that they knew had committed suicide in the last 2 years, and they all said, we knew something was off, we just didn't know what to say. And so we switched the conversation to, if you knew what to say, would you say something? And they said yes. So I think that does hold a lot of promise. We'll see.
Okay. Jeff, we've talked a lot about collaboration, and I think it's clear that this panel and most, if not all the room, thinks it's a good idea. For a second, though, what are some of the challenges that you may have seen when people try to collaborate?
I think we've heard most of it here. We're probably going to do a lot of repeat right now, but the lack of information, misinformation about so many things, and access to health care is one of them. But politics gets in the way. Competition, I don't think we can emphasize that enough. In Eau Claire, the city of Eau Claire, now I am spoiled somewhat. I live in rural Eau Claire County, but I'm really close to an urban center of that part of the state. And in the city of Eau Claire, we always had 2 hospitals. One was Sacred Heart Hospital, has been there. I was born at Sacred Heart Hospital. That's how old that place is. And then, of course, Luther, but now Mayo system. Well, Sacred Heart had always collaborated with Marshfield Clinic as a provider, and Security Health. Well, Marshfield Clinic decided they were going to go a different route. They built a hospital literally less than half a mile away from the Sacred Heart Hospital that they were using. So now Eau Claire has 3 hospitals, and the hospital down the road in Mondovi, about 18 miles away, closed. And so we have this serious issue of it's turned into competition, and how we're going to, and seriously attracting their cancer patients away from another cancer place. We used to have a system in this country where you had to actually apply to get the equipment that you thought you needed, and and that would be determined by the need of the region. And we wouldn't have that competition so much if we would be only caring for the patient's needs. And I think that is lacking. I think that's a huge challenge. And I can't emphasize that enough about how we've gone away from all of that, and we do more and more and more and more. I think it's clear to most anybody in this country that we are on a path and have to be there on this path as soon as possible to a single payer and get away from that competition. I think that's the greatest challenge, but on the way there, the great challenge is politics. And trying to get people to get through all of the stuff they get, whether it be in the mailbox, whether it be on TV, whether it be on talking heads, about why you don't want to have a system like that and lose your doctor. Well, of course, it's so ridiculous because I don't think there are any doctors that are going to be moving away or clinics closing because of the system of payment made to them. That's not going to happen, and we have to do a much better job as a whole, everybody in this room, myself as a leader and politician, and everyone that possibly can talk to people and help them down that path of figuring out, no, you're not going to lose something because we changed the system of how it's paid and who's making all the money. When you look at what's happened in the pharmacy industry and how Purdue Industries has taken billions of dollars while they've been murdering people in this country with nobody's going to prison over that. I think that's clearly demonstrates the problem we have in this country and the challenges that we are facing.
Any additional comments? All right, John, I'm going to switch the last two questions around. And so what was number 8 is now number 7. And how can rural communities work to improve their local economy, which is, we all know, a major social determinant of health?
Yeah. So I would say it varies by community, of course. There's no panacea there. I would say that I think we have to look differently at jobs growth. I think there's a tendency historically to think big, to think let's bring a factory in, let's bring a large employer. And I think what you see in rural is small employers. You see self-employed and small businesses. And unfortunately, when money gets handed out, often at the state or even federal level, it tends to be for larger employers. And I don't think that fits, and they often overlook potential. You've got people in communities ready to start a job start a business or add to their business or expand it, or they're struggling with keeping it open and they could use some help to do that. We have to look to small businesses. So any way that we can support small businesses. Broadband, as you brought up earlier, is essential. It is the 21st century. There is no business that does not rely on internet. So the fact that we can be like, well, we'll just let the market decide that. They've been given a chance, the telcos, to show that they could handle that responsibility, and they failed when it comes to rural areas. And so I think this is one of the areas where we need to have government step in and address that issue, that disparity, because it is a real disparity and it will only grow all of the other disparities more. So we have to get internet access. Some say 5G will be the answer. I'll believe it when I see it. For a while it was white space, from the TV channels that was going to do it, but that means that someone has to pay somewhere for a tower or a line to be buried, and that's a lot of money. And again, why would a company, it's not in their best interest or in their shareholders' best interest to invest that kind of money in something where their return is going to be low because our populations are lower. So it just there's not a return on investment scenario that works for businesses, and we have to do that. We will enable more businesses if we get broadband to them. We will do better if we invest in that sort of Main Street development. Remember that program at the state level? Some of you, as we do more of that and help people that want to start businesses. We're in a negative feedback loop right now. The the fewer resources, the more businesses that are going out of business, the less resources there are. So the ones that are currently existing, there's less for them to be able to collaborate with to do business. Then that means that healthcare providers are not going to want to live there because their spouse and family will not have jobs, which means that the young people are going to leave to the urban areas because there's not jobs, which means that we have a lot of elderly people left there who have no one young to either be a tax base or to serve their needs. We're in a negative feedback loop, and we have to turn that around. And so, yeah, sorry, just to be.
Yep. I would just add personally that I think a lot of us, and I think there's good data to support this, that economic development can work hand in hand with community development, but you need community development often ahead. And two good examples I hear a lot from our members are housing and childcare. So other panelists?
I'm going to add quickly, as long as you mentioned it, and Brett gave me another opportunity to talk about broadband, is that I introduced a package of broadband bills, but one of them specifically is to clearly move that money towards the lowest population. And one of those bills is adding a $100 million grant to the $45 million grant that money that we already have in our budget. And it specifically has to go to counties of less than 75,000. And they have to prove that they are actually providing high speed, which is 25 down, 3 up minimum. And both of those things are not happening right now. We're sending grants out to whoever wants it, and then sometimes they sit on it, they never actually reach the people they say they're gonna reach, or they're actually skipping over those low density population areas and going to the next population pocket to make money. So again, it's the competition, it's the system that we live in, but there is hope in the legislature if I can get some traction with some of these things that I wanted to do. So there's opportunity, but I totally understand what you're talking about.
Well, and I would say that rural can compete. I do think we can be competitive, but we have to have something of a level playing field to compete on. We're some of the most innovative, hardworking people out there, and so if we are given half a chance, we will take the world by storm.
Just have to have access.
Jen or Laura?
Yeah, and just a note on the broadband funding, and I think this is an important issue when we think about policies, and especially funding policies and how they actually play out. This is not my bailiwick. I cannot say exactly how this does pan out, but I do know that with a lot of the funding that's going to broadband, there are requirements about who has to be partners and who can qualify as a partner with those grant funds. And as John was saying, there's a lot of places where the only provider in town is a big company who's not going to take that money and then end up with nothing in the end. And so one of the models that we had talked about a few weeks ago was something like the electric co-ops. I mean, we've seen what some rural communities done with the electric co-ops. Imagine what they could do with a broadband co-op. When we are looking at some of these different funding opportunities, and honestly, the same is true for opioids in rural settings. I'm not saying we don't have opioid issues, but what's worse in rural communities is meth. And guess what? A lot of those grants for opioids, if you're studying if it's meth related, you can't use the opioid money.
They fix that.
Yeah.
All right.
They did fix that though recently. Yes.
Laura?
Yeah, I would just say, reiterate, the transportation, I mean, these are real issues that we need, again, if we're gonna be collaborating, we need to be sitting down and talking about how to address the transportation issues in our rural communities, childcare issues, housing issues. We have people that wanna work for us but can't find somewhere to live because there are housing, and there are developers that want to work, but there are some issues work on developing some additional housing, but there are some issues right now with the expense of the supplies and things of that nature. But again, we have to keep talking about it and keep working to address those issues. They're not gonna go away. It's a marathon, it's a relay race, and we're gonna be continuing to pass the baton throughout now and future generations. And it's not doom and gloom. There's a lot of really innovative, great things going on and outcomes that are positive as a result. But we have to continue, and we have to address these things that are perpetual issues.
Okay, I'm going to go to the audience in 3 minutes, and I'm going to have Jen, you can get the last word on how can researchers be strategic partner?
I think a few things that need to happen is to be a true partner, we need to listen, first and foremost. Leave titles at the door. It doesn't matter what your title is, what your education is, what your background is. When you come to the table to work collaboratively, those things don't matter anymore. It's your lived experience, and it's the ideas that you bring with you. Myself, I say this as someone who is going into a research career that grew up rural. Never walk in the door with a plan. It's just a really bad idea. I already know that. Grew up that way. And in rural communities, you may need different people at the table than you would normally think of in an urban community. So it's really important to be very, very open. I think it's also important to, again, community capacity looks different in different places, and just be mindful of that. I think research can do a better job of looking at metrics that better represent rural than in urban centers. And I think something that's really, really important is it's not rural versus urban, it's not rural or urban, it's rural and urban. We actually exist on a continuum. I think some of the methods that we use have not really done any service to that. I think this is an area that I've just recently learned about, and I'm very excited about it, is actually looking at things spatially. So spatial sociology for anyone out there who's interested in that. But it's actually looking at how space influences our behavior, how close we are to things. So rather than just tagging, saying I'm rural, you're urban, and putting a tag on us about our geography, it doesn't actually tell you anything about how that space influences our health. But spatial analyses can do that. So I think there's a lot of promise in that.
All right, I'm going to go to the audience, and Lisa, since I didn't let you say anything before, you can start.
Yeah, I just had a question. Lisa Kilby from Family Health and Clinica. Jen talked about the education programs. I'm curious if you looked at, there are a lot of states that mandate certain percentages of students for certain programs, like MD programs that are state funded, MPPA, that they mandate a certain percentage of the students come from rural areas. Do you have thoughts on that? Has there been any, John, has there been any entertaining of that in Wisconsin?
I will give you my opinion. I did not, so when I did my literature review, it was primarily nurses. I did look at some literature from medicine and pharmacy, however. So there's a bit of information there. Simply recruiting someone from a rural community is not going to get them to go to a rural community and get them to stay there.
Right, but your odds are better than whether, if all of your students come from urban areas.
Yeah, so what I would say is if you have the infrastructure to recruit students from a rural community and support the students from that rural community through a program, I don't think it's a bad idea. But if you don't have those supports and you aren't mindfully and purposefully integrating rural, then don't do it. It's not going to get you what you want.
Nurse educators.
Yes, and Senator Smith is not going to let me forget this. So I'm sorry, Tim, I have to say this. Where we're really hurting right now actually is faculty.
Yeah.
Most people don't realize this. In Wisconsin, on our last workforce survey that we did in 2018, on average, it took 25 years from the initial degree that nurses earned to become an RN until they earned a PhD. It's 25 years. Now, the reason I chose PhD and not another degree is in order to continue training nurses in nursing schools, you need to have a PhD. The DNP, you can have some of those, but you still need PhDs. And if we continue to train people at the rate of, 25 years over the course of your lifetime it takes, we are actually, right now, we're actually going to be losing 40%, we're on par to lose 40% of the nursing faculty workforce in Wisconsin within the next 5 years. We can't replace that.
We're turning away students.
Yeah, we're not even close to that. So we are actually in a very critical place. We have students who want to go into nursing. We have people like me who would have loved to have been a faculty member a whole lot sooner, but couldn't afford it. So I now have a mortgage, and then I have a mortgage, which is also my student loans. So I think it's really important, too, that we look at how do we support nurses and other health disciplines where we're probably going to see similar trends actually get the training that they need to continue to train the people within their field. Because right now, I can tell you, you do not make as much money as a starting out nursing faculty. You don't make very much. I'd make a lot more working on the floor, tell you that now. I actually took a pay cut after I got my master's degree and started in education. Then my very first nursing job out of college, took a $25,000 pay cut. Gives you some sense of how that goes. So there's no incentive really for us to go into nursing education. So it's a huge issue.
And I would say too, it's a whole Candyland pathway to get from a kid to a provider who's practicing. I mean, we have to have pipeline programs. Wisconsin, along with the rest of the U.S., lost Eich funding for pipeline programming. That was devastating. When you look at, then you've got rural students getting in and the tracks and all of that. Also, when even if we could, so my wife just got into PA school, but she was one of 48 people that were given that honor out of 1,300 applicants. And so you say, oh, this is terrible, we should have more PAs. And the PA program and the NP program and the MD programs, et cetera, and nursing, will all turn around and say, where are we going to get them rotations and residencies if they need that? There's no, I mean, GME is kind of, is rough. Yep.
I'd like to get a question or two from
Yep,
the
okay,
back
sorry.
of the room.
It is about time, just so you're aware.
What?
We're over.
Time? Are we over? Oh, darn. Sorry. Well, the panelists will be here for you to ask questions.